Today's lecture is Health Promotion of Infants, Children, Adolescents, and Adults. Today's lecture will span a few different topics. Please know that not all the chapters are covered in entirety and that you will only be responsible for the portions covered in lecture. You should be reviewing chapters 12, 22, 24, and 25 as they are all part of this lecture. As you can see from the slide, the definition of school health nursing comes from the National Association of School Nurses. Currently, there are over 75,000 nurses practicing healthcare in the school setting in the United States. Time for a little history lesson. The role of the school health nurse was first introduced in the early 1900s by Lillian Wald. The role has changed and evolved dramatically over time, due to the rise in complexity of health issues seen within the school system. Linda Rogers Struthers was one of the first school nurses in New York City. She is credited for providing evidence-based practice nursing care across the city. Lillian Wald realized that school nurses were needed to decrease excessive student absences, increase health promotion within the schools and communities, and provide health education within the schools. School health nursing history continued. As the number of school nurses increased, screenings and referrals became more important. In 1969, the Early Periodic Screening, Diagnosis, and Treatment Program was established. What did the EPSDT program do? It accomplished three tasks. One, it recognized that schools can be the focal point from which health care problems are identified. Two, it increased access to preventative and curative services. And three, it ensured appropriate use of healthcare services and resources for children and adolescents under the age of 21 who received Medicaid. Listed above are some of the screenings that are required and performed by the school nurse as a result of the EPSDT program. Those are listed as nutritional screenings, health education, vision and hearing screenings, and immunization reviews. In 1975, the Education for All Handicapped Children Act was enacted. This act allowed children with chronic or complex medical issues the opportunity to obtain an education. Children who had not previously been able to attend school because of health problems were now entitled to a public education. In 1990, this act became known as the Individuals with Disabilities Education Act, otherwise known as IDEA. IDEA strives to grant equal access to students with disabilities and to provide additional special education services and procedural safeguards. This information is also found on page 471 of your text. School health nursing is a specialized practice of professional nursing that advances the well-being, academic success, and lifelong achievement of students. On the slide, you can see some of the ways in which the school nurse functions. They encourage positive responses to normal development. They promote health and safety, help solve actual and potential problems, provide case management services, and work with others to develop student and family capacities for adaptation and self-management. In 1973, the Ohio Department of Education required school nurses to become certified. This action placed school nurses on par with other certified education professionals. The National Association of School Nurses publication, named or known as the Scope and Standards of Professional School Nursing Practice, assists in defining the practice of school health nurses. It seems as though there is a trend towards nurses becoming baccalaureate prepared in Ohio. Majority, 83% of RNs working in Ohio schools have degrees or higher. College school nurse certification programs also require that nurses have a BSN in order to enter the program. However, some nurses working in private schools or institutions may not be required to have the certification or a bachelor's degree. School health nurses practice with autonomy and independent decision making. School health nurses can function as direct caregivers, educators, counselors, case managers, coordinators of care, and child advocates. They advocate for students and provide a safe and healthy school environment to promote learning. They also communicate with families and healthcare providers as needed. As a direct caregiver, the nurse may engage in a health assessment. There are two types of assessments: the individual health assessment and the population based assessment. What are the differences? The nurse collects subjective and objective data during an individual health assessment. This may include information from the child, teacher, parent, or even peers. Data should include the location, frequency, duration, severity, quality, and factors that make the symptom worse. Some examples of an individual assessment may include a child who has fallen on the playground, or even one who is having an allergic reaction from peanuts. The information obtained then guides the school nurse in providing treatment, notifying parents, and making referrals. Screenings are an example of a population-based assessment. Why should screenings be performed when no law requires them to be done? Well, one might say that screenings are essential to early detection and prevention of problems that can impact academic success. Two major ones that come to mind are vision and hearing screenings. School vision screenings actually help to identify sight problems in both of my children during the third grade. My daughter's sight was actually quite poor at the time that she was checked, and so this assessment benefited her learning. Shifting gears a little within the realm of school health nursing, we move on to the Youth Risk Behavior Surveillance Survey, otherwise known as the YRBSS. The YRBSS was developed because our friends at Healthy People 2020, that's right, you didn't think you could go through one lecture and not hear about healthy people, did you? Anyway, Healthy People realized that there was a need for targeted data collection. The data consisted of common health concerns of children and adolescents. The YRBSS is a tool utilized to collect the data. The YRBSS is a biannual report of common risk behaviors influencing the health of our nation's youth. Ask yourself why. Why does anyone care about identifying the risk factors of youth and adolescence? Well, by identifying these risk factors, researchers can analyze the impact of long-term health and well-being on youth. If we recognize the influence of these risk factors early, we can potentially reduce healthcare costs and plan programs for early intervention. This is done both locally and nationally. There are several surveillance categories to familiar yourself with on the slide. These are also found on page 473 of your textbook. They include unintentional injury, violence, tobacco use, alcohol and drug use, sexual behaviors, unhealthy dietary behaviors, and physical activity. A second data collection tool is the School Health Index. The School Health Index focuses on physical activity healthy eating, and safety related behaviors in an attempt to counter common risk behaviors. The School Health Index is important because it can identify strengths and weaknesses of school programs for promoting health and safety. Chapter 25, Occupational Health Nursing. We now turn our attention to the topic of occupational health. The specialty of occupational health nursing emphasizes the identification and control of risks to employee health which occur as a result of physical, chemical, and biological hazards. The worker in the workplace. The occupational health nurse engages in an assessment of both the worker and the workplace. The goal is to establish and maintain a safe and healthy work environment for employees. Occupational health nurses maintain the highest degree of mental and physical well being for workers in any occupation. What contributes to an unhealthy workplace and affects the mental and physical well being of employees? Hazards. Injuries are the most common result of workplace hazards. The healthcare industry alone accounts for a large portion of workplace injuries. Injuries such as sprains, strains, and muscle tears are common among nurses. In my clinical practice, we have many cords along the floor for ultrasounds and monitors, as well as oxygen tubing. This has become a real hazard with employees tripping over them, falling, and then needing time off work due to an injury. Let's now review the list of workplace hazards. Biological hazards are those that result from living organisms and cause adverse effects on people. Some examples include infectious agents, contaminated body fluids, venomous snakes, and my favorite, spiders. Not really, I hate spiders. Chemical hazards are generated from liquids, solids, dusts, fumes, vapors, and gases. Some examples of chemical hazards are drug or toxin exposure, diesel exhaust, aerosols, and cleaning solutions. Physical hazards result from the transfer of physical energy to workers. These are electrocutions from electric and magnetic fields. Another example is radiation exposure. In interventional radiology, all nurses, doctors, and technologists working in the room wear a full lead vest and skirt, along with a thyroid collar to protect us from radiation exposure. We recently received lead glasses to protect our eyes from the formation of cataracts due to the radiation. This is great, considering I've been standing at the head of the bed of the patient for almost 12 years with my eyes unprotected, and I am now at risk for developing cataracts from the physical hazard of radiation. Lastly, psychosocial hazards. These are all organizational factors and interpersonal relationships in the workplace that may affect the health of workers. This is the psychological stress that occurs when you work in a toxic work environment. Stress caused by incivility of your preceptor or another coworker. Drama between coworkers. Sexual harassment, assault, and violence. Do not let these go unreported. They're not normal and should not be occurring. If your preceptor is causing you psychological stress that is making you sick, then they should not be precepting and you need to find another preceptor. Speak up for yourself, and if you are being sexually harassed, report it. It's not normal. Again, be prepared to identify and provide examples, and these are located on page 527 of your text. Occupational health nursing history. Ada Maya Stewart was considered the first industrial nurse. She conducted home visits to workers and their families, provided emergency care, and taught healthy living habits. In 1942, the American Association of Occupational Health Nurses was established. This is a professional organization for nurses working in a business setting, dedicated to the health and safety of workers, worker populations, and community groups. The intent of the AAOHN is to improve occupational health program services while enhancing career opportunities for occupational and environmental nurses. In 1970, the Occupational Safety and Health Act, known as OSHA, was established. OSHA is the federal agency that sets exposure standards and is responsible for the enforcement of safety and health legislation. The mission of OSHA is to prevent work-related illness and injury by setting standards and regulations related to exposure hazards and training programs. While working in healthcare, most of you will perform a yearly OSHA competency. The occupational health nurse is responsible for record keeping. The nurse utilizes an OSHA log to collect data on occupational injuries, accidents, and illness that occur within a 1-year time frame. This information is then reported to the Department of Labor. The occupational health nurse role and responsibilities. Educational requirements of the occupational health nurse include a valid RN license, a BSN with at least 3 to 5 years nursing experience. Nurses need to be certified in occupational and environmental health nursing. They must adhere to ethical standards as with any other nursing practice. Primary responsibilities include injury prevention and health promotion, including recognition of conditions that may harm the individual worker or the community. The occupational health nurse promotes health through education or through assessments done prior to starting a new job. Those of you seeking a job in the hospital setting will go to the occupational health nurse for drug screenings and physicals prior to starting your new position. The occupational health nurse also recognizes conditions that may harm the individual worker or the community. This is assessed by means of a workplace walkthrough. Here, hazards should be identified. Some of the roles of the occupational health nurse include clinician, case manager, counselor, consultant, health promotion specialist, manager administrator, and researcher. As a researcher, the occupational health nurse would identify, analyze, monitor, measure, and evaluate the effects of workplace exposure. Moving on to Chapter 12, where we will be discussing the difference between care management, case management, and concepts related to home health care. More and more Americans are choosing to be cared for in the home setting. The demand for home health care is trending upward. This is due to increased longevity, the trend toward escalated healthcare needs for those over the age of 65, and improved technology. Hospitals have assisted in implementing the concept of home health care, in part because of the desire to control costs for the client and create a continuum of care. The care given in the home setting is often managed and directed by a registered nurse. The nurse practices in variable environments and conditions, serving a complexity of illnesses. Home health is regulated by the state and federal government, as mentioned on page 208-209 of your textbook. The following groups generally receive home health care, and those are people with acute illnesses, people with chronic illnesses, individuals with a new health-related situation, older adults, and mothers and newborns. Now, we will discuss the types of home health agencies and the concepts associated with home health care. There are a few types of home health care agencies that we will discuss. The first being private voluntary agencies. These are typically not for profit and are usually governed by a voluntary board of directors and community based advisory boards. Any profit that is made through the home care is reinvested back into the operations. An example is the Visiting Nurses Association. Next are hospital-based agencies. Hospital-based home health care has become more prominent within the past 25 years. In an effort to save money and maintain control of client care costs. Again, as mentioned earlier, creating that continuum of care which promotes quality of patient care. 3. Assisted living. Assisted living is community-based care that is semi-independent living with the ability of nursing care to be provided on site or through home care visits. Assisted living is for those not ready to go to the nursing home, yet they may not want to be totally alone, or they lack family support to stay by themselves. Some key concepts to discuss in home health care are homebound, case management, and care management. These concepts are utilized in multiple aspects of patient health care. Homebound refers to the condition based upon how difficult it is for a client to leave the home. Leaving the home must require a taxing effort for the patient. Payment for certain home health or health programs may be centered upon meeting the criteria for the definition of homebound. Case management is a collaborative process, meaning collaborating with multiple healthcare disciplines to assess, plan, facilitate, and advocate for services to meet the healthcare needs of individuals. Care management is the term used to define the evaluation of healthcare interventions, including the need and appropriateness of care, and to evaluate the actions taken to obtain the outcome. All healthcare professionals must collaboratively work in the best interest of the patient regardless of the home care setting or the ability to leave the home. Case management and care management ensure utilization, collaboration, and awareness of services and quality of care are met for the client in which they serve. Question. David is reviewing the regulations for home health care. Who regulates the provisions of home health care? Please look over your options. Then look to page 208 and 209 of your text or the previous slides for your answer. Chapter 24, Palliative and End-of-Life Care. Community and home-based end-of-life palliative care and hospice care are becoming necessary due to an aging population. Remember from earlier, those over 65 have an increased need for care due to a rise in health issues and concerns. Yet another reason it is more prevalent is that people just want to die at home. The job of the hospice or palliative nurse is an intimate one that advocates for quality of life, educates, guides, and supports the patient through a serious illness or the dying process. It is key that the nurse learn how to acknowledge and accept death as a natural process. This will take time. When your first patient dies, It will be a traumatic and stressful event for you as a new nurse. Through your experience, you will be able to come to terms with the dying process and gain comfort in knowing you were able to comfort your patient and the family in the journey. I just want to share that there are times when the family may have no clue the seriousness of the patient's diagnosis. There have been at least 2 incidences in my career that I can recall in which I pulled the family aside and spoke to them in depth about their family members' wishes and suggested that they may want to start preparing to say goodbye. This is a difficult conversation to have. Again, acceptance that death is a natural process is so important. The families were grateful that someone took the time to speak with them honestly about their parent or family member. Arrangements were made, and family was able to come see the patient before they died. This was not only comforting to the family, but also to me, in knowing that I was there to help in the process. End-of-life care. Patients and families face difficult decisions about end-of-life care. There seems to be a fine line between what is considered aggressive treatment and knowing when to stop treatment because it has become futile. Nurses, doctors, clergy, and social workers collaborate to counsel patients and family members about the prognosis, treatment, and plan of care. All too often it is the nurse who is doing the counseling because we're the ones at the patient's bedside listening to the patient's needs. Once decisions are reached about how to proceed with the plan of care, the plan needs to be documented. Usually, this is done in the electronic hospital record. Now, let's discuss some categories for end-of-life patient care planning. Comfort measures. Comfort measures are a plan of care that specifies nursing interventions designed not to treat the disease, but to improve pain and quality of life. This is a plan that allows death to occur naturally while maximizing comfort. Typically, the patient and family has considered going with a less aggressive plan of treatment and care. Comfort measures emphasizes quality of life, not length of life. A patient with comfort care can still receive hospice care. Please refer to the link attached to the slide. For those of you unfamiliar with specific plans of care, you may find the descriptions helpful. These are from the Cleveland Clinic, but most descriptions are standardized, and you will want to familiarize yourself with these upon starting your new jobs in your chosen facility. Advance directives. Advance directives are legal documents signed by the patient indicating his or her choice for medical treatment or naming another person to make the choices if they are unable to do so. That person would then be considered the power of attorney, which takes effect once the patient is unable to communicate their wishes any longer. An example is the living will. Encourage your patients to bring a copy, have one on file at the doctor's office, and one in a safe place at home. I also encourage all of you to have a conversation with your partner or spouse about your wishes and fill out a living will. Artificial hydration and nutrition. We need to educate our patients and families about the risks versus benefits of starting nutrition and hydration. Placing feeding tubes and starting IV fluids for this purpose is believed by some to prolong life and prevent starvation. Research shows that actively dying patients do not experience hunger, and complications can arise from G-tube insertion, such as aspiration or infection, which only complicates matters. Again, I cannot stress enough to you that you should be advocating for your patient and for their well-being. I have seen patients in their 90s on their deathbed with a DNR order that still get feeding tubes because the family has become the power of attorney and is adamant that they want it placed. They are the POA, and so it gets done. Moving on. CPR. Long-term care facilities and hospitals must ask patients and the surrogates whether they wish to initiate CPR in a cardiac event. This being said, CPR is less effective for those nearing the end of life. Literature cites that there is a less than 5% survival rate. A DNR order involves the patient, family, physician, and nurse. Again, the link I provided gives some examples of DNR orders that you will encounter. In your practice, you will need to know what the abbreviations stand for. You do not need to know them for the testing in community health. Euthanasia and physician-assisted suicide. Some of you may have heard the name Jack Kevorkian. He was very prominently in the news back in the 1990s for completing over 130 physician-assisted suicides. Euthanasia is the practice of ending life of a terminally ill patient or to limit the suffering at the request of the patient. It is legal in only a handful of states, including Vermont, Washington, and Oregon. Some of the medications we give for pain relief, such as morphine, have the unintended consequence of shortening life. The intent is to relieve pain and not cause death. Therefore, it is not considered euthanasia. Again, this is a fine line. You may get an order to start a morphine drip on a patient that is dying. You need to keep in mind the intent of the medication. If this is something that goes against your personal ethical beliefs, then you may need to ask another nurse to switch patients with you. Just something to consider for the future. The last two slides will discuss palliative and hospice care. Palliative versus hospice care. Palliative care is the interdisciplinary team-based care that is focused on the relief of suffering for clients with serious illnesses. This is the time when caregivers are looking to achieve the best possible quality of life, not only for their clients, but also for their families. Those suffering from acute, serious, life-threatening disease or progressive chronic disease, such as a stroke, MI, or cancer, can receive palliative care. Hospice care is the support and care for persons in the last phases of an incurable disease so that they may live as fully and comfortably as possible. Those that qualify for hospice care usually have 6 months or less to live, and this has been determined by 2 physicians. Here, everyone is in agreement that the dying person should receive care and comfort as opposed to aggressive medical treatment. Patients can receive hospice care in a magnitude of settings such as home, a nursing home, a long-term care setting, and hospitals. A multidisciplinary team assists the patient in carrying out his or her last days in comfort. Palliative care versus hospice care. Continued. The focus of palliative care is controlling symptoms, coordinating care, reducing unnecessary tests and futile interventions, and having ongoing conversations with the client and family, which is so important. Hospice care is the delivery of quality end-of-life care, providing comfort through pain management, assisting the family and patient through the stages of grief, having those conversations which are so important to make sure everyone's needs are met, assisting the client and family with the dying process, and assisting the family after the death of a loved one through grief and loss counseling. Hospice cares for the body, mind, and spirit. As a new nurse and going through your nursing career, you will find that caring for a patient during the end of life process can be difficult at times, yet it's also very rewarding. This concludes our lecture for today. Please feel free to contact me if you have any questions regarding today's material. Thank you and have a good night.